touch this ear with this shoulder. So like this. Like this. So see, I can do it more, but he cannot do so. Now right side, can you do like this for me? Right. So could you do like this for me? Move. So I can do it more. You can see, I can do it more and more. I can do it. So we can see the spine as well as the movement all together. Turn back, sir, for me. Once again, come. So yes, my dear doctor, listen very carefully. The station 5, you'll get the scenario outside the room. And this man here is written that Mr. X, the 50 years old, has increasing difficulties mobilizing and performing his job. So if you get a case like that just before entering the room, then you need to think the first diagnosis, the ankylosing spondylitis. Yes, my dear doctor, if the case is something like that, the main concern is the unable to perform his own job and also difficulties in mobilizing. So you need to focus onto the full ankylosing spondylitis, full assessment that you need to do. Means that you need to examine and you need to talk the head to toe, whatever the problems he has. Means the ankylosing spondylitis, all the complications that you need to evaluate, all them together. So here's my dear doctor, is because we already know that ankylosing spondylitis is a seronegative spondyloarthritis. And this seronegative spondyloarthritis is having all the A's bundle pack that you need to remember, all the A's that you need to know. So if you start from the eyes, that there will be the A for anterior uveitis or iritis. That is nothing but the red eyes or the painful red eyes. And if you get down to the lungs, there is an apical zone lung fibrosis. So once again, A for apical zone lung fibrosis. If you get down to the heart, then once again the rule of A for AV block, that can be first degree, second degree, third degree AV block. And as I said, that the bradycardia is a feature, or maybe the pacemaker scar and the pacemaker box will be there. And the heart complication, once again, the A for aortic regurgitation. So you'll get the murmur for the early diastolic murmur in the left heart interstitial space. And also you'll get the pulse, the high volume collapsing pulse. And next to the heart, another heart is the A for amyloidosis. Once again, I say the amyloidosis equal to RCM plus NOS plus AHS. What does it mean? The amyloidosis is equal to RCM, restrictive cardiomyopathy. So in that case, they will get the apex bit will be the heaving in nature. And then the NOS is the nephrotic syndrome, urine dipstick will give the idea that the massive proteinuria, and the nail, you'll get the leukonychia, and the leg edema, you'll get the leg edema. So these are the features that you can expect. And next is an abdomen examination, the hepatosplenomegaly that you'll get for the amyloidosis. So yes, once again, that you come back from the anterior uveitis, apical zone fibrosis, AV nodal block, aortic regurgitation, and then amyloidosis that leads to the restrictive cardiomyopathy in the heart, and A for rule getting down to the abdomen, then you get the hepatosplenomegaly. Means the amyloidosis equal to hepatosplenomegaly and the NOS, nephrotic syndrome, and the restrictive cardiomyopathy. And you get down to the thighs and the legs. These are important matters that you need to know. Means the joints is really important. Means in ankylosing spondylitis, the axial joints is involved. Means the spine, means the spondylitis, the spine joints is involved. Means the cervical spine, lumbar spine, the whole spine will be involved. Axial joints, along with the SI joints, the sacroiliac joints. Other than the axial joints, the appendicular joints are also involved. We call it the asymmetrical oligoarthritis. So there will be the asymmetrical oligoarthritis. We call the mono is a single, and the oligo is a 2 to 5 joints, and poly is a more than 5, is a 6 joints. So there may be the small joints in the hands, or maybe the right ankle, or maybe the left wrist joint, or maybe the left knee joint. So in an asymmetrical varieties, oligoarthritis may be present. So arthritis, A for arthritis, legs, the A for arthritis rule. So here's the axial joints arthritis and also asymmetrical oligoarthritis. And getting down to the legs, these are enthesitis. A for enthesitis, yes, you can say. So A for enthesitis means that the Achilles tendinitis and also plantar fasciitis. There is lots of A's. And last is the Coda A equina A syndrome. It's a Coda equina syndrome. So head to toe, these are the features that you can expect in a patient with the ankylosing spondylitis. But this gentleman having a concern with the mobility problems. So you need to show all the features of ankylosing spondylitis and I will show all the possible features that he has of the ankylosing spondylitis, rather than going through the systematic ways of Station-05 approach. But getting the findings in your hands, that you can formulate the things in the real exams and making the diagnosis and saying the examiner and also your patients as well, so that you can get the full marks in Station-05, 28 out of 28 marks, my dear. So what you need to do, you need to look at him to see at the general survey and to see any of the walking aids that he has, and also the prism glass. That is really important. And immediately after that, you have seen the surroundings, bedside surroundings. Then you need to look at the eyes, and you can ask him, is there any painful red eye? So he doesn't have the red eye, no painful red eye. And also to just open his body, it will be helppful for us. Sir, could you just open the body so that we can get the findings in our hands? So yes, that we can see the psoriatic rashes, because the seronegative spondyloarthritis also associated with some extra-articular manifestations. So yes, the psoriasis skin rash may be associated or maybe present in that case. So you can do can you do like this for me, sir? And you need to look at these areas and these areas for the psoriatic skin rashes. Thank you, sir. Thank you very much. And you can go back to him just to see the back of the ear and back of the ear and below the hairline scalp. So he doesn't have any of the psoriatic skin rashes. So what we need to do, we need to look at him, that his spine and everything at general survey. And I'd like to see him that little bit walking, just forth and back. I'd like to see the spine, the full spine, and the movement of the neck and the lumbar spine all together. So I'd like to tell him, sir, would you please just stand up for me and just walk for me? So I'd like to show his spine. So you can see the cervical spine is hyperextension, and also the loss of normal lumbar lordosis. So you can see a question mark posture that the gentleman have. So yes, there's nothing but the congestion, the ankylosing spondylitis that he has. So now let's see, he will walk for me. Just walk. So now we can look at him. So he's walking, so we can see the posture at him. So we can see the back. And now we can see the posture. Yes. So turn back, sir, now. Turn back for me. Turn back. Yes. Yes, sir. So turn back. So we can see the spine as well as the movement all together. Turn back, sir, for me. Once again, come. Walk for me. Yes. Now turn back once again. Turn back. Yes. Bas. Turn back, sir, for me. Turn back. Wait, sir. Turn back. So yes, sir. What we can observe, that he has the question mark posture and the ported belly as well altogether. So yes. So this is nothing but the locomotor system examination, and that starts with the look, feel and move. Then you already observe him and the question mark posture with the restricted movements and hyperextension of the cervical spine and also loss of lumbar lordosis. So this is look that we have found that he has got the ankylosing spondylitis with a protuberant abdomen that he has. And now the feel. Feel is really important to see any of the tenderness of the spine that he has or not. So we need to turn him. So, sir, can you just turn back? Yes. Turn. Like this, yes. Now I'd like to feel of your spine. If you have any of the pain, just let me know, sir. Just feel the spine. Is there any pain, sir? Pain? All right. Which part? Here is the pain. So he's feeling the pain. Yes, he has got the pain. So he has the spinal pain. So he has some of the tenderness. So I need to feel the spine. So this is the tenderness that you need to look for. So this is the look, feel. And now that we'll go for the movement. So sir, what we are going to do now, we'll see the 6 important movements of the cervical spine. how much and to what extent they're restricted that we can observe here. So we need to tell him, just sir, could you please just like this, do like this for me? So you can see I can move my chin and very close to my chest, but he is unable to do so. Do it more, do it more. So you see the great distance is here. So this is the flexion movement. Now the extension. So can you do like this for me? More, more, more. So see, I can do more, but he is unable to do so. So really restricted movement, the flexion and extension altogether. Now, sir, can you just touch this ear with this shoulder? So like this. Like this. So see, I can do it more, but he cannot do so. Now right side, can you do like this for me? Right. Could you please touch with your right ear with the shoulder? So really a great distance rather than me. You see, I can do it. Yes. Now the lateral rotation. So just turn round to move your head on the left side. Like this. I can turn around. You can see I can turn around. And you can see the difference is me with him. And now on the right side, you can see I can move, but he is not moving the way that I'm moving. So the 6 important movements, the cervical spine is really restricted. The flexion, extension, lateral rotation, and the left and right side movement, my dear. So the 6 important movements are really restricted in the cervical spine that you already observed. So yes, now we look for the spine movement of the lumbar spine movement. So we'll tell him, sir, could you do like this for me? Move, move. So I can do it more. You can see I can do it more and more. I can do it. I can do it. So this is called the floor finger distance. So you can see the difference. The floor finger distance is more than that of me. You can see I can do it more. So there is a forward flexion and the backward movements. So I can do it more. So definitely he has got the restricted movement. Now the lateral bending. With the lateral bending, so I can do it more. You can see I can do it more. Now right hand side, right. I can do it more. Yes. So now with the lateral rotation, that we can see that I can do it. With me that you can compare, and now you see that I can do it more. So yes. So these are the 6 important movements that we have done, that he has got the restricted movement in the lumbar spine as well. Now we'll do the modified Schober's test. That's very important to see the restricted lumbar spine movement as well. So these are the modified Schober's test. I'd like to make a mark point here. So there's a dimple of Venus, and then you need to put your hands and then you just make a good mark here. So you need to give the 10 centimeter above a marking and the 5 centimeter below here. I'm just putting mark over the clothes, but you shouldn't do that. So now we need to tell him, just could you please, without bending your knee, just touch your feet. Just bend, just a minute. Yes, bend now, bend more. So this is increasing only the 16, 17 maximum. So yes, thank you very much. So in a normal person, that is 15 centimeter in total. In a normal person with the bending that goes more than 20 centimeter, means more than 5 centimeter extension of the lumbar spine or interspinal space altogether. But here is only 1 centimeter increase. This is said that if it is less than 5 centimeter is increase, so this the Schober's test or modified Schober's test is positive. So his Schober's test is positive. So this is the finger floor movements. So if you can make it, you see, this is around 50 centimeter. So finger floor distance is 50 centimeters. So in a normal person, the finger floor distance is less than 10 centimeters. In his case, the 50 centimeters is so increased. So the 10 centimeters. So now we are seeing the chest expansion that you need to measure. You see this is around 99 centimeters. So you can tell him, take a deep breath in. More. So this is no or less movement. It is less than 2.5 centimeters positive. So yes, his movement on the chest is reduced. So sir, can you just make it more close to the wall? So this is we call the occiput wall distance, usually 0. If I can touch, just can you go there? That's right, sir. So we can compare with him. So you see the long distances. So that should be 0. You see, if I touch, I can touch. I can touch. Is it locating here that I can touch? I can touch, yes. So I can touch, but he cannot touch. You see, this is 0. He has got the long distances. So this is occiput wall distance 0. Chest expansion is a 2.5 centimeter. More than 2.5 centimeter chest expansion should be. And the Schober's test, more than 20 centimeter. And the finger floor distance, more than 10 centimeter. So 0, 2.5, 15, 20 and 10 centimeter that we need to remember. So yes, my dear doctor, this is the Station-05. So whenever the scenario says that he has got the increasing difficulty in mobilizing and performing his job, that you need to do all the maneuvers and showing all the features altogether. So my dear, listen very carefully. Then you need to know the 0, 2.5, 5 and 10. What I said, the 0, 2.5, 5 and 10. What does this 0 mean? 0 means O for 0 is O, so the occiput. So this occiput wall distance, that should be 0. It is increased. So definitely the number 1 findings that you found. And next, the 2.5 is the chest expansion. So normally more than 2.5. If it is less than 2.5, yes, this is also positive test. And then 5 means the Schober's test. Means the 15 centimeter normal, and more than 5 centimeter added means the total 20 centimeter. More than 20 centimeter is normal, but less than, in his case, there's only 1 centimeter. So this positive Schober's test as well. So 5 centimeter, as I said. And last, the 10 is a floor. 10 is a floor. Yes, means the finger to floor distance, less than 10 centimeter. In his case, the 50 centimeter. So yes, so you need to remember the 0, 2.5, 5 and 10. Then you need to show the examiners these are the things, along with the cervical spine movement and the lumbar spine movement altogether, showing them that yes, the diagnosis is ankylosing spondylitis. Yes, my dear doctor, listen very carefully. What you need to do, you need to explain him regarding the ankylosing spondylitis. And after that, what is the management plan that you need to do that? Sometimes the Station-05, the scenario will be something like that. The man is presented with the shortness of breath on exertion. So yes, my dear doctor, he entered in the room that you have seen. He has got the ankylosing spondylitis. Now the shortness of breath on exertion, the differential diagnosis that you need to think about. Number 1, the apical joint fibrosis. And secondly, the heart disease. The heart disease includes maybe the aortic regurgitation leading to the chronic heart failure, the number 1, or maybe restrictive cardiomyopathy having heart failure, or maybe the third AV block leads to the heart failure. So yes, the heart disease, and the first one, what I said, the lung disease. So shortness of breath on exertion, what you need to do, you need to lie back in 45-degree angle, then you need to examine the pulse for the high volume collapsing pulse for the aortic regurgitation, and you need to put the stethoscope and also put the hands for the apical impulse for the thrusting displaced apex bit, and also put the stethoscope to get the early diastolic movement. Along with the findings, as I said, the first degree, second degree, third degree AV block, any of the scar mark for the pacemaker, or maybe the restricted cardiomyopathy for the AICD pacemaker scar. So these are the cardiovascular system examination. I also put the stethoscope directly onto the apical zones to get the crackles, to get the findings. So findings will be directing you to what is the likely diagnosis, and the patient may be concerned with the heart failure. So yes, my dear doctor, that whenever the station 5, the case is with the shortness of breath on exertion, that you need to think about the lungs disease first, the apical fibrosis, evidenced by the crackles, or the second differential diagnosis, the heart disease, the aortic regurgitation, maybe the severe aortic regurgitation leading to the left heart failure. These are two important diagnoses you need to think about, and you need to make the patient lie back onto the couch, and 45-degree angle, you need to put the stethoscope onto the apical zone and put the stethoscope onto the left lower sternal zone for getting the murmur of early diastolic murmur, and also the features of severity like the high volume collapsing bars and the thrusting displaced apex vein, and also the short EDM, and also the lungs crackles, the basal crackles for the heart failure features. So yes, my dear doctor, I hope that the ankylosing spondylitis, with all the complications and with all the possible examinations that we learned from this case and formulate all them together based on the scenario that we need to approach to this case, and asking him regarding the concerns, what is really his concern, then management them, and make a good planning further will be helpful, my dear. I hope that, my dear, you enjoyed. Thank you very much.